I'm making this video as an endorsement and giving information about what are the duties in OB-GYNE department. Separate in ward, what are the duties, in ER, what are the duties, and in OPD, what are the duties. So I have Doc Valerie with me. So we'll start with OPD first. So Doc, as you go in OPD, so first, what are the things that you have to do? What are the things that you have to manage?
Because in OPD we have two kinds of patients, the new patients and the old patients. So for new patients, they usually just accept 10 patients. So for those 10 patients, we need to take their history and at the same time their vital signs. So for the SOAP, it's up to the residents. They are the one who's gonna do that. So after that, for the old patients, we also need to take their vital signs at the same time. So their BP, their temperature, their SpO2, their RR, their CR, and at the same time their weight, like that. And also, for those patients who are for prenatal checkup, follow-up, we also need to take their fetal heart tone. So basically, all pregnant ladies that are for prenatal checkup, we need to take their fetal heart tone at the same time, so that when the doctor arrives at around 8 a.m., they already have the fetal heart tone, so it will be less time consuming, so we can finish early.
Correct.
And at the same time accommodate all the patients early, because the patients usually fall in line around 3, 4, 5 a.m.
Yeah. Okay. So I would like to inform, in our hospital the OPDs are on OB OPDs are on Tuesday, Thursday and Friday, and the other days Wednesday and Monday it's gynae OPD. So a part of OPD is ultrasound.
Yeah.
So I'll inform about ultrasound is that in ultrasound 2 of the clerks have to go there, and the one clerk who has already attended ultrasound last time, they have to endorse the new clerks. So what actually they have to do in ultrasound is they have to take the receipts and fill the entries that and if they have the payment receipt, so they have to enter that and put them in the serial order, and then go inside the ultrasound room and help the consultant, the doctor who is doing the ultrasound. The ultrasounds of two types. One is transvaginal. Actually, transvaginal is for the patients who are having some kind of sexual contact or something, but those haven't have any sexual contact, they have transrectal ultrasound. And other is BPS, which is biophysical scoring, and one more is pelvic ultrasound. So these are done in the ultrasound room. And other than that, we have to note down for each patient that what things are told us by the consultant. In OPD, after the receipt, after the history taking, and after the vitals are taken, when the patient comes back from the doctor, so whatever doctor has suggested, for example NST is suggested, so we have to do NST. For example, pap smear or things are suggested, then we have to do those things, right? Yeah. Assist in the pap smear and all. So after all the patients are done, so we get sheets for in OPD the sheet is only 1 or 2 pages, right?
Yeah.
So we have to transcript all the written things in the laptop, right?
Yeah.
In the Excel sheets, encode it in Excel sheets. So as compared to the ward census, OPD census is comparatively easy. So that's not much hectic, because in OPD ward census it's full chart which we have to encode for each patient. So after OPD we'll discuss about ward duties, right? Yeah. So Doc, as you go in the ward, what are the things that you have to handle for different kinds of patients? First, how many different types of patients can be there?
There can be bleeding patient.
In ward. Yeah, okay.
Preeclampsia patient, of course pregnant patient, and patients who are critical. So basically patients who are pregnant and at the same time they have comorbidities such as diabetes or hypertension. And then we also have patients who are having malignancy. and at the same time patients who are, what you call this,
So
who are
bas-
having miscarriage.
Yeah. Okay. So based on the duties, we have to do Q4, like Q4 vitals for everyone in the
Yeah,
ward.
yeah.
Each patient in the ward, we have to do Q4 vitals.
Yeah.
In the vitals, we have to check the blood pressure, the respiratory rate, pulse rate, SpO2, and
The RR.
RRA respiratory rate is done. Okay. Blood pressure. Okay. So these are the things which you have to monitor every 4 hours for each patient in the ward. Additionally, there are some patients who are under blood transfusion. There can be patients under blood transfusion. For them, we have to measure the Q15.
Every 15
Q15
minutes.
is like every 15 minutes we have to take vitals until it is instructed by the nurse. It's approximately how much after the blood transfusion?
And maybe around 1 to 2 hours.
1 to 2 hours after the blood transfusion also. Yeah, okay.
Because we need to take Q15 during the blood transfusion and at the same time after the blood transfusion. Yeah.
In the ward, there are patients with blood transfusion who are instructed for Q15 vitals. There are some other patients who are instructed for FHTs. Mainly the instruction depend on the residents and the nurses, what they instruct about. But mainly the patients with comorbidities, for example, hypertension or diabetes, they are instructed for FHTs in the ward, right?
Yes, po.
So-
and also NST Q4.
Q4 NSTs in the ward, right? So NSTs can be Q4 or once a day. So after this, in the ward, the main thing which remains is the census, right?
Yes, census. Like you know, census.
Yeah. For the ward, census is a kind of headache which takes 3 hours, 2 hours, 3 hours approx.
Because you need
And
to encode.
encode.
Like, the chart.
Exactly.
And understand
The
that
almost the
it's
whole
like-
chart, everything for the patient, all the tests which has been done, right? All the medications which has been
Physician's
received,
orders.
all the physician's orders. So everything has to be encoded,
Yes.
and it's a kind of headache in the ward, especially. And the main problem in that is in any kind of census is that understanding the handwriting and encoding that. Sometimes words are, one of the incidents I remember that there was written
Perfume.
it's profuse bleeding for the patient, but the clerk was able to read PR something, so he wrote that perfume bleeding. Wow. So it's like that. The understanding the handwriting is one of the main headaches.
Also the vital signs. Because like imagine we have 20-30 patients and
Yeah.
you do all those
Yeah.
patients vital signs.
The timing of the vitals is generally 8 a.m., 12 p.m., 4 p.m. Again, same for the night batch. It's for 8 p.m., 12 a.m. in the midnight, and 4 a.m. in the early morning. So we have to wake up the patients to take vitals.
Yeah.
So, and the patients who are with Q15, they are though like sometimes we have to take on a stretch 30-40 vitals for the same patient, and the patient is so much fed up
Piss
of
off.
this. Correct.
They're kind of pissed off already. Like, I mean, they want to rest, right? And then we're just one thing we realize for our group is that whenever some group endorses you what to do, you need to double
Yeah,
check
exactly.
it with the resident.
Sometimes you have to double check the endorsement received by the previous group which is just outgoing batch.
Yeah, because sometimes it's
Sometimes,
like choppy
yeah,
for them
correct,
also.
correct.
I mean, it's
Because
not
they
their
want to
fault.
go home early, so they are instructing you in very hurry. Some things they are also leaving, and yeah.
Sometimes if something happens, it's your group who's gonna take the fall or take responsibility.
considered responsible for that. Okay.
Yeah.
So now we'll move on to the ER duties, which is the main and the most important.
Yeah,
things.
the most exciting one.
Most exciting also, and most faults are also done here, like most
Everything's
vulnerable
here.
kind of.
Yeah.
Yeah, you can
You'll
say
see
that.
the most unseen things here.
Correct. So we'll move on to that.
Okay.
Now talking about the ER duties.
OB-ER duty.
OB-ER duties. So first thing is that we have to change our the scrub whenever we enter the ER zone. Like ER zone is sterile zone. There is two zones: sub-sterile zone and sterile zone. So there is changing room there. You have to wear the green scrub, the mask, the head cover. We are
The
right now in
gloves.
The Crocs of the ER are different that you wear outside. You cannot use the same Crocs outside also. If seen, then you will get demerit immediately.
So if you want to go out, basically when you come here in the hospital, you need to be in your civilian attire or maybe your maroon scrub.
Correct.
And then different shoes. And then once you come inside the ER, before going to the sterile area, you'll be having a changing room where you will change into your green scrubs, which is the one that we're wearing now. And then at the same time, your new Crocs. And at the same time, your head cap and face mask.
In
and
case we have to go outside for some work, for example, for having food or buying something, so we have to wear the white lab coat and change the Crocs. That's important. So this is about the scrub. Now heading onwards to the duties which are important. So whenever a new patient comes to the ER,
First,
so you continue with the.
So basically, not all are admitted right here in the ER. So
Correct.
there are some patients that are just for like they're just gonna be observed by the doctors or by the residents. So basically, for example, in the ER there are many kinds of patients. Also, for example, this patient is not for admission. She's just on labor. And she's just like 1 cm, 2 cm, and she's not like very in critical. So basically, the doctors will just monitor her for NST. So basically, before she goes into the labor room, she needs to be in a lab gown.
Correct.
And then she's gonna be asked to lay down in the bed, and that's where we
have
put
to
her NST.
Hook the NST, correct.
And usually it's 20 minutes.
Yeah, 20 minutes. 4 pictures we have to send to the residents. And then generally, if they are satisfied with the pictures, they will say to unhook and send the patient. And for the patients who are admitted, so what are the procedures which are done in serial order? Like
and guys, before the patient, for those patients who are not admitted, they are also IE'd first before they are asked to do anesthesia.
Yeah,
so
correct.
when they come, they're gonna be asked to sit in the chair, lying upside down table, and do IE. And when the IE is like this, just anesthesia, and then go back. And then for those patients who are admitted, so there are patients who are really like, they're gonna give birth already, like they're 5, 6, 7, 8, 9, 10, and really in labor and continuous contractions for, like, for example, it's 5-1-1. So in 5 hours, there are 1 minute contraction every 5 minutes for 1 hour. So, ayun.
So for these patients, they are admitted.
Yeah,
right?
they're gonna be admitted. So
And
for admission,
yeah, those patients who are admitted, they have to fill the form first, and you have to send because you are in ER, you cannot do the census. So you have to send the first picture. It's called blotter of the patient admission to the ward, so that they can perform the census for the ER patients also.
and we need to do history to all admitted patients.
So we will begin with the history taking of the patient. So it's a like detailed history, and after that the IV line is inserted to the patient, through which medications are given, right? And blood extraction is done for the patient for the blood test,
And urine analysis also.
urine analysis, and also the skin test, right?
Yes.
Skin test is
Skin
done
test usually it's when they're for CS.
only for CS.
Usually it's for CS.
Okay. So these are the tests, and yeah, the thing is,
They're also for NST monitoring sometimes.
yeah, the thing is that if a patient is admitted and the patient is in the ER, she has to be at all times hooked to the NST. Point 1. If the machine is not available, oxygen also. If the machine is not available, we have to do manual monitoring of the
And at the
patient.
same time, the FHT.
And in every 15 minutes we have to check FHTs of the patient if the patient is not connected to the NST machine. And if the patient is connected to the NST machine, we have to check the tracings. The NST machine should be adjusted to 3 centimeter per minute scale, and then we have to send pictures every 5 minutes to the residents.
And also at the same time, we need to do vital signs every 1 hour. Q1.
Yeah, Q1 vitals for every patient. This is compulsory for every patient.
And
So yeah.
Yeah, that's it.
So what are the procedures which are done in ER?
Usually it's just normal spontaneous vaginal delivery,
Correct.
cesarean, and then DNC or dilatation and curettage.
Okay.
For those-
So DNC, NSVD, and CS. Other than this, no any other procedure?
Other than that, so far nada.
Okay. So when the dilation of the patient is how much? So that what are the indications that
10
the patient
cm.
will be done the NSVD?
10 cm.
10 cm. After every 1 hour, the resident do the
IE. 2 hours, every 2 hours.
2 hours, every 2 hours. So after every 2 hours, or depending on the seriousness of the patient, they will do IE. Then the clerk have to ask the doctor what is the how many centimeters is the dilation.
But not all 10 cms are
Yeah.
for spontaneous vaginal delivery, because like there are some patients who are already 10 cm but they're still, the baby's head is still out.
Yeah,
so
that's
it's
why.
like dysfunctional
That's why.
labor. So
It's a combination of NST also, and the dilation also, and the comorbidities also, what the diseases the patient is having. So depending on that, the resident will decide whether the patient is NSVD or CS.
yeah.
Okay, so these two things. For example, a patient is going for NSVD. Now what are the things that you have to do in, what are the duties you have to perform during NSVD?
So first of all, we need to put the patient in the
Delivery room. First, we have to transfer the patient. Then
we
have
need
to check
her
the
oxygen,
Yeah.
and then check her BP.
BP during the procedure.
BP.
And during the procedure also we have to check the FH, fetal heart tones.
But when she's contracting, you cannot check the fetal heart tone.
Okay, and the clerk who is assisting the doctor, then
He needs to wear a sterile gloves.
sterile gloves. He or she has to wear the sterile gloves. And
We also need one clerk for the sodium chloride.
Irrigation. It's called irrigation. It's called irrigation. I was not able to
Okay.
remind the term.
And
So
at
it's
the
called
same
irrigation.
time, when the baby comes out, the placenta will come out. Sometimes the resident will ask you to assist in
Placenta out.
placenta out.
Okay. Also, the PDA has to know
Yeah, we
the
need to
timings.
inform
We don't
the
have to
media
know the
patients.
timings.
Yeah.
We have to inform the PDA clerks also when the patient is transferred to the delivery room immediately, or the patient is transferred to the CS OR operation. We have to immediately report to the PDA clerks also.
Yeah, because they'll be the one who will be noting the time, the delivery, the upper score, and everything else. Details of the baby.
Correct.
For the normal delivery, after the delivery, the doctor usually will do episiotomy suture, and after that, the patient
is transferred to the recovery room, and we have to take Q15 like vitals every 15 minutes for the patient until the patient is transferred to the ward.
Yeah, because there are two kinds of CS: elective CS and emergency CS.
Yeah, please explain.
So for elective CS, meaning elective, so basically you pick a date for which day you wanna do the CS. But it depends on the resident, not us, of course.
And the other type of CS is emergency CS.
For those who are like already pooped, like meconium.
Meconium aspiration or dysfunctional labor, right?
Yeah, because the baby might.
If the residence is monitoring for the patient for a long time and the labor is not proceeding, and the patient is or the patient is also having some comorbidities, for example hypertension or something, so
diabetes.
Diabetes, so the patient
these are the comorbidities.
the patient are referred to the cesarean section. So what you have to do, for example, you are the one who is going to assist the CS.
So for example, we wear these green scrubs already, but in the operating room we need to
scrub in the operative scrub, right?
Yeah.
So for that we have to wash the hands till elbow, and we have to wear the sterile gloves and wear the gown, and then keep them up to here, not above, not down, like that,
like the proper downing and gown.
Exactly. So other than that, you have to stay close to the the patient, not far away. That all will be
just
instructed
do the
by
proper duffing and donning. So you just need to put your hand like that, and
keep yourself sterile, basically.
Just put it on her or not.
Correct. The other clerk will be instructed to, as soon as the baby is out, baby is delivered, it is handed over to the PDA department, and after some time the PDA department will send the baby outcome. So one of the clerk, other than the one who is assisting, one of the clerk has to go in the OR and announce the baby outcome to the patient, mainly the birth weight and the maturity index and the Apgar score. These three things are important.
Yeah.
So this is also one of the duties.
Yeah.
So other than this, in CS, after the CS is done, the patient is bring back to the operation OR recovery room, and then the same thing we have to monitor the patient. Oh yeah, Q15 every 15 minutes.
Vital signs.
The one thing that is remaining is DNC. Anything remaining about CS?
No, nothing.
So it's like that. So we were almost done with the discussion of the endorsement. Only DNC was remaining since at the time doc director came here, so that's why we have to pause that. So now the next thing is about the DNC. So DNC is like dilatation curettage. It represents like the patient comes like the patient has heavy bleeding, vaginal bleeding, and she sees something coming out meaty substance coming out. So
that means it could be incomplete abortion.
Correct.
Because
that can be incomplete abortion. It means that some portion has come out already and some portion is still remaining inside the uterus, which has to be taken out. So you were saying that when the patient is admitted, then there is nothing for us for?
Yeah, for 8 hours there should be NPO, nothing per order. So they should have not taken any food or any drink, because if they took any, they could be in danger during the procedure because they will be under sedation, right? So they could go into asphyxiation or like
asphyxiation.
Yeah.
Okay.
So that's why there should be nothing there. Nothing for them. So that's why usually it's 8 hours in the IV.
So the doctor will ask for one clerk to assist in DNC, and then one of us will go there. You mainly have to note down the timings when the first injection is given, when the second injection, when the diase is given, right?
And the diase. Usually the Novain after the domain is injected first, and then after 15 minutes the diase is injected second.
And we have to monitor the BP before the procedure, just before the procedure and just after the procedure finishing. We have to note down the start time and the end time of the procedure.
Yes.
Okay.
Both.
And the patient and the clerk who's assisting the doctor, he or she may have to wear the sterile gloves in order to hold the things, because we cannot use these hands. It's a operative procedure, so we have to use sterile gloves there also to assist the resident. So this was about dilatation curettage. After that also the same thing, when it comes out of the operation theatre, operation room, then one clerk has to, usually the same clerk has to monitor the patient Q15.
Yeah, usually for
in every 15 minutes, usually for 1 hour, right?
Yeah.
After that, the patient is transferred to the ward.
Yeah.
And one thing which was remaining was pre-duty.
Yeah.
Pre-duty is nothing, it's just like OPD, but it's just having less number of patients, usually less than 10, right?
Yeah, or usually more than 10 to 15.
10 to 15 patients. 15 are very rare. I never seen 15 patients, right?
Yeah, I mean, approx that number. Or 10, or less.
Tuesdays, Thursdays and Fridays are OPDs, which are considered OPDs. The others are considered pre-duty. And the Monday and Wednesday, that is for gynae. So usually they are less than 10, 12 patients like that. So it's more less hectic comparatively compared to the OPD. Yeah. It's upon the group how they will manage the less hectic things. They can keep the less number of clerks and others on standby like that. They can manage the duties like that. And when it's more hectic, they can call the standby clerks. So actually, this was asked by some of my friends who are coming to the OB-GYNE that they need endorsement. So I make this video. So thank you so much. Subscribe to the channel.
Subscribe to Amit channel.
Yeah.
Please.
Thank you so much.